အားလုံးပဲမင်္ဂလာပါ NUG Weekend Teaching မှာကြိုဆိုပါတယ်ဒီနေ့သင်မယ့်အကြောင်းအရာက neck lump ဖြစ်ပါတယ် ENT surgeon UK မှာ ENT surgeon ဆရာကနေပြီးတော့သင်ကြားပေးမှာဖြစ်ပါတယ်ဆရာမင်္ဂလာပါဆရာ
မင်္ဂလာပါ Okay, so today we talk about the neck lumps. This is a big topic. There's so many lesions, so many causes of the neck swelling, and it is difficult to finish, to talk about all the neck swellings in the 45 minutes. So I would just talk about the outline, the management and investigation and management of the neck swellings. This slide not moving to me. What's going on? Okay. So the summary of these sessions include the anatomy of the neck and epidemiology, the prevalence and distribution of the neck swellings, what are the differential diagnosis, and what should we ask in the history, and what should we examine the patient present with the neck swellings. And then I would talk about the general, investigations and treatment outline for the patient with the neck swellings. Okay, so before we start the neck swellings, I will explain briefly the anatomy of the neck. There's the two diagrams. The first diagram is, this is the anatomical division of the neck regions. So the boundary of the necks are, the upper border is the lower border of the mandible, anterior border is the midline, the posterior boundary is lateral border of trapezius muscle, and lower boundary is the clavicle. In the neck, we have the key muscles. These are very important for surgeon, and they can divide the various triangle of the neck, and these are the landmark when we operate the neck. So the obvious muscle is the sternocleidomastoid muscles. It divides the anterior and posterior part of the neck. And then there's another two key muscles in the neck. This is the anterior and posterior belly of digastric. And another key muscle is the omohyoid. So this is we call is anatomically submental triangle, submandibular triangle, the carotid triangle. This is the anterior muscular triangle, and the posterior is the occipital triangle, and carotid triangle. So the next diagram is, this is clinically important. In the clinical practice, we use this type of what we call classification. This is the level of the neck. So this is a first level. Basically, this is a submeta and submandibular triangle. And level 2, level 2 is the upper, what we call jugular chain. Level 3 is a middle chain. And level 4 is previously we call is a supraclavicular fossa area. And the posterior triangle is a level 5. And level 6 is the front part. This is the midline. So that's why it is useful. So for the diagnosis, we can see if the lesion is at which level, and we can tell where it's coming from. And then it's also important, for the treatment. For example, if it's head and neck cancer patient, we need to consider which level of the lymph node should be removed, because it's a level 1 or level 2 clearance, or level 3 or level 4, like that. So it is useful. So in the daily practice, we use this type of the classification. So the level of the neck. And this is what we call the lymphatic drainage of the neck. So this is a submental. I will start with the submental area. The submental area is usually it is not significant. So it can be, it can drain from around the skin or from the lip. In the submandibular areas of the lymph nodes. So it's drained from the oral cavity, like a teeth, gum, tongue, cheek, and sinuses. This is actually the level 2 area, jugulo-digastrate. Previously, we call it the jugulo-digastrate group of the lymph nodes. So it drains from nasopharynx, tonsillar area, tongue base, and parotid, and the sinuses. This is the level 3 area. Previously, we call it the jugulo-omohyoid group. So it comes from the oropharynx, hypopharynx, and yeah, this is the level 3 group, and it can come from the what we call is tongue base as well. And this is a lower group. This is a level 4 area, and the previously we call it a supraclavicular fossa. This area come from thyroid and the hypopharynx and upper esophagus, and we need to take care. It can drain from the below the clavicle, like from the breast or chest or even from stomach. The posterior triangle is, generally speaking, clinically, it is not significant. It is drained for around the skin, scalp, and maybe post-auricular area or from the pinna. Okay. So another structures which can give the neck swellings are thyroid glands and thyroid glands. There's 3 pairs of thyroid glands. The one pair is parotid, and another pair is sublingual glands, and another pair is a submandibular thyroid glands. Okay. Who gets what neck lump? So this is what we call prevalence, of the neck swellings, and it's what we call is we can divide the group. It's roughly we can divide the group. It's a common swelling and rare neck swellings. Okay. So when you look at the common swellings and the acute, this is acute swellings are most likely due to the infection. So it can be the bacteria, it can be due to the bacterial infection, it can be due to the viral infection. So the common virus are cytomegalovirus. So we call this is a granular fever, and Epstein-Barr virus, and Staphylococcus, Streptococcus, and Toxoplasmosis. It is what we call is the parasitic infection, and after the upper respiratory infections, it can present with the enlarged lymph node in the neck as well. Okay, so squamous cell carcinoma is another common presentation. It can present like a metastasis lymph nodes. So it is usually it's come from upper aerodigestive tract. And then another common another swelling in the neck is thyroid swellings. So it can be benign or it can be malignant. Okay. Other uncommon swellings are due to cyanidinitis. It can be parotitis or submandibular cyanidinitis, and EV fistula, Barcelona infection. It is because it's a crush disease, and hematoma and HIV infection. It can present with the multiple enlarged lymph node in the neck, and tuberculosis infections. It can be atypical tuberculosis as well. We call it a cool abscess or and parotid and the parotid lesions and the aneurysms. These are amyloidosis, lymphoma, metastasis, cancer, and the parotid tumor sarcoidosis, Sjogren syndrome. This is a present like a enlarged parotid glands. These are the brachial cysts. Sorry. And this is the congenital cysts. This is a carotid body tumor. This is a chemodatoma. Okay, this is another chemodatoma is glomus jugulare tumor, glomus vagal tumor, and Rango C, the lipoma and thyroglossus cysts. These groups are rare, very, very rare swelling. These are the virus and granulomatosis disease. Liposarcoma is quite rare. Common thing is a lipoma, and it can present like a parathyroid adenoma or adenocarcinoma. So generally speaking, in what we call is, it depends on the age. If it's what we call young age, children and young adult, the common cause of the neck swelling is due to the inflammation, and it can be due to the congenital or developmental lesions. If in adult over the 40s, generally speaking, it can be neoplasms. So it can be benign lesion or it can be malignant tumor. Okay. So this is another classification of the what we call the neck swellings, according to what we call etiology. So the first group is neoplastids. So it can be benign or malignant. So the metastatic lymph nodes, as I mentioned, it is the spread from the upper aerodigestive tract, or sometimes it may come from the chest and esophagus, breast, or even from the stomach. So another lesion is epidermal carcinoma. It is not common. And melanoma, it can present like a neck swelling and the thyroid tumor. So it can be benign or malignant thyroid tumor. And lymphoma. Lymphoma is another, common presentation as a swelling in the neck. And salivary gland tumors, so it can be parotid or submandibular salivary glands. And the lipoma, angioma, and carotid body tumors, these are the benign lesions, rhabdomyosarcoma. It is very, very rare. And what are the congenital or developmental lesions? The common is brachial cleft cysts, thyroglossus cysts, lymphangioma, hemangioma, gum-wide cysts, atopic thyroid tissue, laryngocele, pharyngeal diverticulans, and thymus cysts is also very rare. And these are the common inflammatory swellings. The commonest is lymphadenopathy. So it can be the bacteria, viral, or due to granulomatosis. And tuberculosis, it can present like a enlarged lymph node, or we call it a cold abscess in the neck. In Western country, tuberculosis is rare, but we can see the atypical tuberculosis is common in the children. They can present like a neck abscess. It does not have any pain, no systemic, symptoms. They don't have any temperature. Clinically they are well. And another infection is a cat scratch, sarcoidosis, hidradenitis is due to the stone in the parotid or submandibular or sublingual glands. Another inflammatory or infected, it can present like an infected sebaceous cyst. Okay. This is the next slide. This slide is another classification of the neck swelling. Clinically, it is very useful. So we need to look at, this is a midline swelling, or this is the lateral neck swelling. So I can show you some example. This is what we call is thyroglossus cyst. This is the typical area in the midline above the thyroid cartilage. It is a young age. It can present like a recurrent infections. So this is a infected cyst present in the midlines, and on the examination, the swelling is moved with the deglutition and protrusion of the tongue. So clinically, it is very obvious, but we can confirm with the ultrasound of the neck. And the treatment is surgery. So we go, it's a six-trunk operation. So we need to remove this fibrosis cyst and the duct as well, so to prevent the recurrent infections. This next photo is, this is the diffuse swelling in front of the neck. It is very obvious. This is a goiter. So this is a thyroid swelling. Okay, and this another midline swelling is, this is a sebaceous cyst. It is very superficial, attached to the skin, and we can see phantom in the middle of the swelling. This is a sebaceous cyst, skin cyst. And it can be the level 6 neck nodes. So as I mentioned, in the level of the neck, the level 6 is the midline in front of the neck. Usually this lymph node is around the thyroid gland in the esophageal groove. So it drains from thyroid, trachea, and esophagus. And then in the another midline swelling, it's a submental lymph nodes. Another midline swelling is, we call it a gum-white cyst. This is the developmental cyst. Okay, so we continue for lateral neck swellings. This is what in the lateral neck swelling, the commonest fracture is the lymph nodes. So these are the group of the lymph nodes. We call it a preauricular or parotid lymph nodes, submental, submandibular, jugulo-digastric group, and jugulo-omohyoid. And this is a posterior group along the accessory cranial nerve, number 11. And this is the lower jugular node. This is the supraclavicular fossa. So we can look at this level 1, level 2, level 3, level 4, and level 5. These are the group of the lymph nodes. And we can see the young people with the enlarged level 2 lymph nodes. So we need to think about what we call is oropharyngeal cancer. And 25 years ago, the oropharyngeal cancer is not common, but in our daily practice, we can see the young people present with the enlarged this level 2 neck nodes, because due to the incidence of HPV, human papillomavirus, is increased now. They don't smoke, and they are not related to alcohol consumption as well. So okay, what are the other lateral neck swellings? So the common one is salivary gland swellings. So it can be due to the infection, it can be due to the blockage of the blockage of the duct with the stone, or it can be the neoplastic lesions. In the parotid lesions, most of the cases are benign. The 90% of the parotid lesions are benign. The commonest is pleomorphic adenoma. But even the benign, for the long term, after 5 or 10 years, it can change to malignancy. So we recommend to remove this type of the lesion. In the submandibular salivary glands, there's a chance of 50-50 benign and malignant neuroplasms. So the submandibular salivary gland lesion should be removed. Other lateral neck swelling is the mycobacterial infection. It can be the typical tuberculosis, or it's a common in the Western country is atypical tuberculosis infection. Usually it present in the anterior triangle. It does not cause any pain, no tenderness, and then the child is usually well. Okay. Another lateral swelling is, it can be the brachial cysts. These are the embryology, the development of the neck. There's a brachial cleft, brachial pouch, and brachial arches. So this diagram shows this is a cystic swelling in the level 3 area, just in front of the sternocleidomastoid muscles. So this is a cystic lesion. It is most likely due to brachial cysts, especially in the young and children. But if it in the adult, especially over the 40 years of age, we should exclude the malignant necrotic lymph nodes. So they are very similar to the brachial cysts, but only the difference is the age. Okay, this is the CT scan of the cross-section of the CT image. This is the sternocleidomastoid muscle in front of, this is the mass. This is the cystic lesion. This is a brachial cyst. So bilateral neck lumps, it is not common. Most of the cases are due to the inflammation. This picture shows this lady has a bilateral parotid swellings. So it is most likely due to the viral infection like mumps. One of the tumor, actually this is a benign tumor. It can present like a bilateral neck swelling. This is a Wadding tumor, papillary cyst adenoma lymphomatosum. It can present with the bilateral enlarged parotid gland. It is purely benign. It is not necessary to remove. And this diagram shows the lipoma in the back of the neck. So lipoma, sebaceous cyst, the epidermoid cyst, it can happen any place in the neck. Okay. So, patient present with the neck swelling, what should we ask in the history? So, first we need to focus on the swelling. So we should ask a patient, how long does he or she notice the swelling? So it's become bigger or smaller, and it is painful, and it move with the swelling like that. We should ask in the history. And then we should ask the other regional symptoms, like any dental caries or soreness in the mouth or throat, difficulty swallowing, painful swallowing, or change of the voice or noisy breathing. So clinically, we call this is the reflex symptoms. So it's very important to diagnose upper aerodigestive tract cancer. And we should ask about this obstruction, bleeding from the nose, and earache, especially rhaphaotalgia. Patient with the throat cancer or mouth tonsillar cancers, they can present like a rapha earache, and facial weakness, like a facial nerve palsy, and scalp lesions. If we suspect what we call the lesion enlarged lymph node in the supraphalangeal fossa area, so we should ask about the history about breast, chest, and stomach as well. And so we should ask a systemic symptom as well, like weight loss, tiredness, lethargic, anorexia, fever, night sweatings, and thyroid symptoms. Other relevant history or social history is smoking and alcohol consumption are very important. So 99% of the causes of the upper aerodigestive cancers are due to the smoking and alcohol drinking. I think in Burma, we should ask about the bitter nut chewing as well. And the occupational history and exposure to the what we call radiation in the past, and family history of cancer as well. Okay, so how should we examine the neck? So just like a general principle, the inspection, palpation, percussion, and auscultation, but usually we do the inspection and palpation. Rarely we need to do the percussion and auscultation. So how can we inspect the neck swellings? The important thing is exposure of the neck. We should see the whole neck of the patient. So we should see the both clavicles, and we should inspect patient from front and the side. So what should we inspect? We should look at the swelling, where the swelling is, how big it is, and is there any symmetry or is there any scar? And we need to ask the patient to drink the water. So we need to check the swelling is move with the deglutition or not, and we need to request to do the stick out the tongue. Palpation. Usually we do the palpation from behind the patient, and basically we need to confirm what we see in the inspections. So important thing is we should examine the patient thoroughly to avoid them missing some areas. So there's two methods. Some people start from the top and gradually move to the lower part of the neck. Or some people start from the lower part of the neck and move to the top of the neck. Generally, I start from the top, like a level 1. I start the examine the feel the neck from the level 1, level 2, and pre-auricular or parotid area, post-auricular area, and go to level 2, 3, 4, and level 5. Finally, I examine the midline, so level 6 area. If we feel the neck swellings, we should check mobility, consistency, and the surface edge. Is there any tenderness or not? And overlying skin, if it's persisting swelling or not. Percussion is usually we do if we suspect that it is a thyroid swelling going to the mediastinum. So we need to check the extension of the lower limit of the thyroid swellings. But clinically, we are not doing. So we rely on ultrasound and auscultation. If we suspect it is due to the parasitile lesions, we need to listen the brew. So it can be the aneurysm, or it can be carotid body tumor or AV fistula. And after that, we need to do the other examination as well. So first examination is an examination of the mouth. So we need to look at, is there any lesions in the lip, gums, cheek, tongues, and tonsil. So like, everybody can do on the bedside if you have the like a torch. In the ENT clinic, in the outpatient, we have the fiber optic nasal endoscope. So it is very easy to examine. We can examine the patient with or without local anesthesia. So as we can look at the nasal cavities, both nasal space, pharynx, and larynx. And we need to do the cranial nerve examination as well. The patient have the mainly we need to check with the number 7 facial nerve. And if we suspect this is a lesion is coming from below the clavicle, we need to consider the examination of the breast, axilla, groin, and chest and abdomen. If we suspect the lymphoma the same, we need to examine the chest and abdomen as well. Okay, this is the what we call is a algorithm for diagnosis. So the look at it. This is the pediatric and young adult under the 40. The most common causes of the swelling I explained is infection or inflammation. So if we think the swelling is due to the infection, like patient has the temperature, pain, any signs of inflammation on the swelling, so we should start with the antibiotics. So these are self-limiting conditions. It resolves after 4 or 5 days taking antibiotics. If it is not due to the infections, we need to do the imaging. The first line of the imaging is ultrasound. So ultrasound can differentiate this is a cystic or solid lesion. If it's a cystic lesion, it can be the congenital or developmental cysts like pyrogrossous cysts, brachial cysts. If it's a solid lesion, we need to do the ultrasound guided fine needle aspiration cytologies. So we can get the tissue diagnosis. We can get the diagnosis here. If it's adult over the 40s, it is most likely due to the neoplasm. So we can check with the ultrasound. And if it is a vascular lesion like paraganglioma or hemangioma, we should avoid the ultrasound guided fine needle aspiration cytologies. We can check with the other imaging like CT scan of the neck or MRI scan of the neck. If not, it is a solid lesion, we can do the ultrasound guided fine needle aspiration cytologies to get the diagnosis. Okay. This is the general investigations for neck swellings. This is a general idea, and it can be different in the different type of the lesions. So in the clinic, the first laboratory investigation, so the blood test, like a full blood count and CRP, so, and the thyroid function test, serological test for specific virus or bacteria, like a infectious mononucleosis, tuberculosis, cash scratch, like that. We have the various serological tests to confirm for it. The first and the useful imaging is ultrasound and ultrasound guided fine needle aspiration cytology. So this combined ultrasound and ultrasound guided fine needle aspiration cytologies are very sensitive to detecting the metastatic lymph nodes, and it's very sensitive to thyroid swelling as well. And then other imagings are CT or MRI. So usually for the neck swellings, we check with the MRI scan of the neck, because MRI scan of the neck is very good for the soft tissue in the large lamb and the deep tissue, in the deep tissues, and especially in the upper aerodigestive tract. And if the CT neck is only we use is suspect is there any neck abscess in the neck. And if it's the malignant lymph node, we need to do the CT chest, CT abdomen, and CT pelvis to rule out the metastasis. In UK, what we are doing is we have the one-stop neck lump clinic. So it's run by, ENT surgeon, radiologist, and cytologist to diagnose the, neck swellings on the spot. So ENT surgeon see the patient fast, and then after that, radiologist check with the neck with the ultrasound, with or without ultrasound guided biopsy. Cytology or co-needed biopsy depend on the ultrasound findings. And at the same time, after the biopsy, cytologists can look at the slide in the clinics, and then we can get the provisional diagnosis. So it can save the time, and we can plan for treatment within a week or 2 weeks. See, biopsy of another investigation is a biopsy of the neck swelling. So nowadays most of the cases we are doing with the co-needed biopsy. If the finding the expert cytology cannot give the diagnosis. For example, if we suspect the lymphoma, we need to do the co-needed biopsy to get the decent tissue sample for immunohistochemistry study. The incisional or excisional, these are the open biopsy. Nowadays, it's very, very, very rare now. So, and then if we suspect it is the metastatic lymph node, we need to proceed the pen endoscopy and biopsy for the primary lesions. So pen endoscopy includes laryngoscopy, pharyngoscopy, and upper esophagoscopies. Other investigations are PET-CT and fluoroscopy. Usually, we are not doing the PET-CT scan. If MRI scan of the neck cannot demonstrate any lesions in the head and neck, like unknown primary, so we can check with the PET-CT scan to find out where the primary is. The fluoroscopy like cyelogram and Bayesian swallow is also useful for diagnosis. Okay, so this is the treatment outlines. It's just based on different lesions have a different treatment. So I can explain you only what you got general idea how to treat the patient with the neck swellings. So this is a conservative treatment. For example, like lipoma, sebaceous cyst, dermoid cyst, it is not causing any problem or any pain or infections. We don't need to remove. Even the goiter, it is not causing like not the pressure symptoms like difficulty swallowing or difficulty to breathe, we do not need to remove the thyroid glands. And the medical treatment is like, if it's the infection, we can treat with the antibiotics. Surgical treatments. So, like, if it's any lesions is causing the problem, like infection in the infected cysts, or congenital lesion like fibrosis cysts, breaker cleft cysts, they can cause a recurrent infections. So we need to remove. If it's the neoplastic or this malignant lesions, we need to treat with the combined therapy. So surgery, radiotherapy. If it's the thyroid malignancy, after operation, we can treat with the radioiodine. The chemotherapy and immunotherapy are mainly for palliative treatments of the head and neck cancer. So it can slow down the progression of the disease. Okay, this is my final slides. Takeaway messages. Number one, for differential diagnosis, the age of the patient and location of the lump are the key factor. So I already mentioned about what are the common in the children and the young age, what are the common in the old people, and this is a midline swelling or lateral swelling. So it's very helpful for differential diagnosis of the neck lump. Okay. Another message is be suspicious of the cancer. Like metastasis lymph node, thyroid tumor, salivary gland tumor, and lymphoma. These are the common malignant lesions in the neck. The lymphoma is usually present like a multiple enlarged lymph node in the neck without any pain. They are fast growing. And they have the systemic symptoms like a weight loss, temperature, night sweating. This is the red flag, which you need to refer urgently to ENT. This is the unexplained neck lump that has been over a period of more than 2 weeks, or any changes of the pre-existing lump, like a long-standing parotic lesion or goiter. If it's changed rapidly, we need to investigate. So when the examination of the neck, we should not only focus on the neck lump, we should examine the other part as well. So like mouth, ears, nose, chest, and abdomen. And ultrasound, plus or minus 5 needle expression cytology or co-needle biopsy is the most useful and fast investigation of the neck lump. Okay, this is end of my presentations. Is there any questions?
Okay, so I did. Did you mean question the crew your how to palpate systematically so that no area are missed mutation?
Yes, sorry, I already explained, So just for, well, usually I explain, from the top, like, I can show the diagram, just one moment. Okay, so just look at the diagram. So what we call systematically, we can examine from the anterior. This is what we call is, I explain the level 1, yeah? We can start with the level 1 and then go to the parotid or preauricular area, and we can go to post-auricular area, and then go to along the sternocleidomastoid muscle, the level 2, level 3, and level 4, the supraclavicular fossa, and then go back to level 5 in the posterior triangle, and finally go to midline. This is a level 6. So we can go like that. So we cannot mix the, the area in the neck.
Okay, so that is the mention. Not the Kuajaro, how to do needle aspiration for cytology.
Yeah. Generally, we are not doing the what we call the fine needle aspiration cytology. Because the radiologists, they can hit the target, they can hit the the right sample from the suspicious area. So what usually radiologists do, they use the 22 or 23 grade needle, put onto the swelling, and that exactly where the suspicious area is. So they can take the sample from this area. We call it a ultrasound guided, fine needle aspiration cytology. So radiologists can do that. So we can get the, what we call right sample.
Okay, so I choose it to measure. I could also time machine there. There are check out the check illusion, maybe only the Kali ladder edition.
Okay. Oh yes, one of the pan endoscopy. I already explained. Pan endoscopy means this is what we call examination of the patient under general anesthesia. So we check with the what we call is pharyngoscope and laryngoscope and upper esophagoscope. So basically, we need to look at the thumb base, epiglottis, and arytenoid area, peripheral fossa, and we can look at all the vocal cords and upper esophagus.
Okay, so if one neck gland is palpable, is it abnormal?
That's right. Yeah. So even in the normal lymph node, normal lymph glands, usually it's below the 1 centimeter side. It is not possible to feel. So if we can feel the nerve gland, it means the nerve gland is bigger than 1 centimeter side. It is most likely the pathology in the lymph node. Only exception is some people with the very thin neck, sometimes we can feel the submandibular salivary glands. So it is the normal glands, but due to the low fat in the neck, very thin neck, so sometimes we can feel, but clinically difficult to tell this is the normal submandibular salivary gland or not. So we need to check with the ultrasound. Now the ultrasound are very what we call sensitive and specific for the neck swelling. So they can tell, the radiologist can tell us it is a normal structure or it is a abnormal. If it's the abnormal, it's a benign or it is, you know, like a malignancy. So it's very specific now. So ultrasounds are very good investigation in the neck swelling.
ဟုတ်ကဲ့ကျေးဇူးများတင်ပါတယ်ဆရာအမိဒီဘက်မှာတော့မရှိသေးဘူးရှင်
ဆရာတကယ်လို့ကျောင်းသားတွေတို့နောက်မှဒီမေကွန်းနေရှိတဲ့ခါကျရင် email ဒီ Myanmar Surgical Society UK@gmail.com email ကိုပို့ဖို့တော့ပြောထားပါတယ်ဆရာ
ကောင်းတယ်ဟုတ်ပါဆရာကြိုးစားပြီးတော့ပြပါမယ်
ဟုတ်ကဲ့ပါဆရာအဲ့ဆိုအချိန်ပြည့်သွားပြီဆိုတော့ဒီနေ့ဟိုလက်ချာလေးကိုဟိုပိတ်လိုက်တော့မယ်နော်ဆရာ
Okay thank you
ကျေးဇူးအများကြီးတင်ပါတယ်ဆရာပြချာလေးတင်ပေးတယ်
ဆရာကျေးဇူးတင်ပါတယ်
ဟုတ်ကဲ့ရှင်